Welcome back guys. Now let's discuss about the changes in the GFR. In the previous video we have discussed how exactly glomerular filtration happens. Okay, how filtration is happening, that already we have seen in the previous video. Now let's discuss about the alterations in the GFR, the changes in the GFR. Okay, with the different scenarios the GFR will alter. For example, let's see here. See, this is the afferent arteriole. So afferent arteriole, what it is going to do? Afferent arteriole is going to bring the blood to the glomerulus, and in the glomerulus filtration is going to happen. Okay, and the blood is going to go out of the efferent arteriole. So bringing the blood, here filtration will happen and blood will go like this. Okay, now point to be noted here, this is the afferent arteriole, this is the efferent arteriole. Afferent arteriole brings the blood, efferent arteriole takes away the blood. Now see, in this condition what exactly we are doing? See, the afferent arteriole is getting constricted. Now you are constricting the afferent arteriole. See, when you constrict the afferent arteriole, what will happen? When you are constricting the afferent arteriole, the amount of blood going to the glomerulus, what happens? Decreases. The amount of blood going to the glomerulus decreases. So what happened to the GFR? GFR decreases. Okay, with afferent arteriolar constriction, if afferent arteriole is constricted means the amount of blood coming to the glomerulus decreases. The pressure generated in the glomerulus decreases. So automatically what happens? GFR decreases. GFR decreases. Now question is, who is going to constrict the afferent arteriole? Okay, which substances are going to cause the afferent arteriole? It's a norepinephrine and adenosine. Okay, so norepinephrine or adenosine, they will cause afferent arteriolar vasoconstriction. Whenever there is afferent arteriolar vasoconstriction, there is a decreased blood flow, decrease hydrostatic pressures, so automatically decrease in the GFR. Now let's talk exactly the opposite thing. What is that? Say here, this is the afferent arteriole. Now afferent arteriole is dilated. Now if afferent arteriole is dilated means, now think logically and tell me guys what happens. Now afferent arteriole dilated, more blood is coming to the glomerular capillaries. Okay, more blood is coming to the glomerular capillaries. If more blood is coming to the glomerular capillaries means more hydrostatic pressures. So more filtration is possible. More filtration is possible. So what is happening? GFR increases. With afferent arteriolar vasodilation, okay, with afferent arteriolar vasodilation, what happened to the GFR? GFR increases. Okay. Now, question is, who is going to cause the afferent arteriolar vasodilation? The afferent arteriolar vasodilation is caused by prostaglandins. Okay, prostaglandins are going to act on the afferent arteriole, will cause the afferent arteriolar vasodilation. Now, afferent arteriole part is completed. Afferent arteriolar constriction, afferent arteriolar dilation, both are completed. Now let's talk about the efferent arteriole. Efferent arteriole. Efferent arteriole is going to take the blood away from the glomerulus. See, in this first condition, what we are doing to the efferent arteriole? Now the efferent arteriole is getting constricted. We are narrowing it down. Okay, you are just narrowing it. Now if efferent arteriole is narrowed down means, okay, if efferent arteriole is narrowed down means, what will happen to the GFR? See, blood is coming, blood is unable to go out. Okay, see, blood is coming via afferent arteriole, it is going to the glomerular capillaries. Okay, now it is not going out. When it is not going out, see, outflow tract obstruction, now it is not going out means blood is going to accumulate inside the glomerular capillaries. So more hydrostatic pressure will be there. Okay, see, just like imagine like there is a garden hose, there is a pipe, you just close the opening. What happens? Back pressures are generated. In the same way, when you constrict the efferent arteriole, back pressures are generated. So there will be more hydrostatic pressure in the glomerular capillary that increases the GFR initially. So initially, yes, GFR increases. But later what happens? See, blood is not going out. So automatically the amount of blood that comes in will also decrease. Okay, because back pressures are getting generated, right? So eventually the amount of blood that will come will also decrease. So what happens later? Later GFR decreases. So initially GFR increase, later GFR decrease. So this is called as a biphasic response. Okay, this is called as a biphasic response. So now tell me, biphasic response is seen with, okay, biphasic response in the GFR. Okay, initially it increases, later decreases. This response is called as a biphasic response. Now this biphasic response is seen with efferent arteriolar constriction. And who is going to cause the efferent arterial constriction? Even the RAS pathway we have discussed, angiotensin 2 receptors are present on the efferent arteriole. Now this angiotensin 2 causes efferent arteriolar vasoconstriction. Okay, angiotensin 2 causes efferent arteriolar vasoconstriction, so that causes changes in the GFR. Okay, done. Now let's talk about the efferent arteriolar dilation. Okay, efferent arteriolar vasodilation. Now if efferent arteriole is dilated means, okay, if efferent arteriole is dilated means what happens? Blood is coming in, going to the glomerular capillaries. Now blood is not going to stay over there. It's not going to stay. Why? Because see, the efferent is wide open. It is dilated. So easily, very easily, blood is going out. So blood is not going to stay in the glomerular capillaries. So what happened to the hydrostatic pressure in the glomerular capillaries? The hydrostatic pressure in the glomerular capillaries decreases. Why? Because blood is not going to accumulate here. Blood is very easily going. Okay, blood is very easily going. Why? Because the resistance in the efferent arteriole became less. Now it is dilated. So very easily blood is going to go away from the capillaries. So hydrostatic pressure decreases, so GFR decreases. So efferent arteriolar dilation. Okay, whenever the efferent arteriole dilates, so what happened to the GFR? GFR decreases. Not initially, just normally GFR decreases. That's it. GFR decreases. Now question is, who is going to dilate? Okay, who is going to dilate this efferent arterioles? Now we have seen efferent arteriole is constricted because of angiotensin 2. Now why there is this angiotensin 2? Because of the RAS pathway. Angiotensin 2 is because of the RAS pathway. Okay, now see, RAS pathway is renin is going to convert angiotensin 1 into, angiotensinogen into angiotensin 1. The angiotensin 1 will be converted into angiotensin 2 with the help of ACE enzyme. Okay, if you want angiotensin 2, the angiotensin converting enzyme is needed. Now if you use this ACE inhibitors, angiotensin converting enzyme inhibitors, what happens? There is no angiotensin 2. Whenever there is no angiotensin 2, what happens? Efferent arteriole is dilated. So that decreases the GFR. Very, very important clinical point. Okay, at the end of this video, we'll discuss about something which is called as why we should never use ACE inhibitors in a patient who is suffering with bilateral renal artery stenosis. Okay, that we will discuss later. But anyway, ACE inhibitors, what they will do? ACE inhibitors decreases the GFR. Okay. Now, after this, see, we are discussing what? We are discussing about the changes in the GFR. See, now in certain conditions, GFR is getting decreased and certain conditions, GFR is increasing. Now, after this, let's discuss about the GFR changes due to mesangial cells. Even these mesangial cells can control the GFR, can regulate the GFR. How, sir? Now, look at here, guys. This is a glomerular capillary. Okay, this is a glomerular capillary. Now, how we can say this is a glomerular capillary? Because please look at here, all these gaps are there. What are these gaps? These are the fenestrations. All these are the fenestrations. Now, these glomerular capillaries, they are surrounded by cells. Okay, this is a cell which is surrounding the glomerular capillary. This cell is called as a mesangial cell. Okay, mesangial cell. Now, these mesangial cells, they can undergo contraction and relaxation. Okay, mesangial cell contraction and relaxation. Now, you think logically and tell me, see, if this mesangial cell, if it contracts, okay, if it contracts, what happened to this glomerular capillary? Glomerular capillary is going to undergo constriction. When glomerular capillary undergoes constriction means, what happened to the GFR? GFR automatically decreases. Simple, right? So, mesangial cell contraction increases the GFR or decreases the GFR? Decreases the GFR. It decreases the GFR. Okay, not increase the GFR, decrease the GFR. Why? Because the mesangial cells, they are going to contract, compress the glomerular capillaries. When the glomerular capillaries are compressed means, okay, when the glomerular capillaries are compressed means, the amount of blood flowing through the glomerular capillary decreases, so automatically GFR decreases. In the same way, the opposite thing. So, if mesangial cells are relaxed means, okay, if the mesangial cells are relaxed means, what happened to the GFR? GFR is going to be increased. Okay, GFR is going to be increased. Why GFR is increased? Now mesangial cell is relaxed. Now the glomerular capillaries are dilated. More blood flow is there. More GFR, more the GFR. Okay. Now point is, this mesangial cell contraction is caused by which agents? And the mesangial cell relaxation is caused by which agents? Okay. Now please concentrate here. The contraction of the mesangial cells is mediated by substances like endothelin. Okay, the endothelium produces this substance called as endothelin. Endothelin will cause contraction of the mesangial cells. Angiotensin 2 can also cause contraction of the mesangial cells, and norepinephrine. Okay, endothelin, angiotensin 2, norepinephrine. Like the sympathetic neurotransmitters. Like this is also something sympathetic nervous system, angiotensin 2 and endothelin. All these three are going to cause the contraction of the mesangial cells. And let's talk about the relaxation. Okay, this relaxation of this mesangial cells is mediated by substances like nitric oxide. Okay, nitric oxide. What is the important point about the nitric oxide? See, this nitric oxide, it uses cGMP as its as its secondary messenger. So nitric oxide uses cGMP as a neurotransmitter. When this nitric oxide, when it acts on the mesangial cells, in the mesangial cells, it increases the levels of cGMP. Okay, it's a secondary messenger. And nitric oxide is also very important for your exam. Nitric oxide is derived. It is derived from which amino acid? It is derived from arginine. Okay, it is derived from arginine. Okay, and let's talk about the natriuretic peptide. See, atrial natriuretic peptide, brain natriuretic peptide, which is coming from the atria and ventricles. Okay, so the natriuretic peptides and even CAMP, natriuretic peptide, nitric oxide, all of them will cause the relaxation of the mesangial cells. Relaxation of the mesangial cells will cause increase in the GFR. Okay, increase in the GFR. So again, the GFR can be increased, decreased, changes in the GFR due to mesangial cell contraction and mesangial cell relaxation. Now after this, let's discuss about a topic called as autoregulation of the GFR. Okay, even GFR will be regulated. Okay, so the autoregulation of the GFR. In order to understand the autoregulation of the GFR, you need to know about an apparatus called as JG apparatus. Okay, JG apparatus. So what is this JG apparatus and where it is located and what it consists of which cells? It consists of which cells? So please concentrate on this area. Okay, this is the afferent arteriole which is taking the blood to the glomerulus. Here is the glomerulus. This is the afferent arteriole which is taking the blood into the glomerular capillaries. And this is the efferent arteriole. This is the efferent arteriole. Okay, now see here, I am zooming up this area. Okay, I am zooming up this area. See, this is the afferent arteriole. Or let me draw a simple image. See, let's understand like this. Now, this is afferent arteriole. This is efferent arteriole. What are these blood vessels? These are glomerular capillaries. Okay. Now, what is the structure which is present over here? This is Bowman's capsule. Now, after this Bowman's capsule, here is a proximal convoluted tubule. Now, after proximal convoluted tubule, here is the loop of Henle. Okay, this is descending limb of loop of Henle, hairpin turn, and ascending limb of loop of Henle. Now, here you will be having distal convoluted tubule. Okay, this is the distal convoluted tubule, and later you will be having collecting tubules, collecting ducts, kind of thing. Now, see, on this afferent arteriole, okay, on this afferent arteriole, there are certain important modified cells present. Okay, there are certain important modified cells present. The smooth muscles of the afferent arteriole, they are modified. Now, these modified cells which are present over here, these modified smooth muscle cells of the afferent arteriole, they are called as, okay, they are called as JG cells. Okay, they are called as JG cells. Okay, they are called as juxtaglomerular cells. Okay, juxtaglomerular cells are also called as granular cells. Juxtaglomerular cells are granular cells. Okay, so we know what exactly are these JG cells or granular cells. Now, this is the DCT. Okay, this is the distal convoluted tubule. Okay, this is the distal convoluted tubule. Now, in the early part of the distal convoluted tubule, now some important epithelial cells are modified. Okay, some important modified dense epithelial cells are present. Okay, dense cells are present. Okay, which are like which are dense in nature, which are dense, compactly present. Now, these cells are called as macula densa. Okay, they are called as macula densa. Now, you know macula densa. Where exactly is the macula densa present? Macula densa is present on the distal convoluted tubule. Juxtaglomerular cells are modified smooth muscle cells of afferent arteriole. In between them, some connective tissue cells are present. Okay, in between them, some cells are present here. These cells are called as extraglomerular mesangial cells. Okay, these are called as extraglomerular mesangial cells, which are also called as 𝗠𝐞𝐼𝐻 cells or 𝐿ASIC cells. Now, all these three structures together, okay, all these three structures together called as a JG apparatus. Okay, it's together called as a JG apparatus. Okay, why we are calling it as a JG apparatus? JG means juxtaglomerular. JG, juxtaglomerular apparatus. See, here is a glomerulus. Okay, here is a glomerulus. Now, side to the glomerulus, there is an apparatus present which is called as a juxtaglomerular apparatus, which is very important for the autoregulation of the GFR. Okay, autoregulation of the GFR. Now, see, what are the three important parts of the JG apparatus? The three important parts of the JG apparatus are JG cells or granular cells. Okay, macula densa, which is present on the early part of the DCT. Okay, and extraglomerular mesangial cells or 𝐿ASIC cells or 𝗠𝐞𝐼𝐻 cells. Now, After seeing what exactly is the juxtaglomerular apparatus, now let's discuss about the autoregulation of the GFR. Okay, your kidneys only know one thing. Okay, your kidneys, your nephrons only know one thing. What is that? At any point, okay, there should be normal GFR. Okay, your kidneys all the time want to maintain the GFR, that is 125 ml per minute. All the time they want 125 ml per minute GFR. Okay, for example, in any condition, if GFR increases, okay, there is this one condition where GFR is unnecessarily getting increased. Okay, hyperfiltration, more filtration is happening. Do you think more filtration is good? No, it's not good. Why? Because if more filtration is happening continuously 24/7, the kidneys will be damaged. Okay, the kidneys will be damaged. The Bowman's capsule, the glomerulus, everything will be damaged. Okay, your glomerular filtration barrier will be damaged because of so much of filtration. It cannot take that much load. So there is increased GFR means what should happen? There is increased GFR, you need to decrease the GFR. Okay, there is so much GFR, that GFR should be brought down to normal. Okay, so how exactly it happens? It is done with the help of our juxtaglomerular apparatus, or it is done with the help of macula densa in specific. Okay, now whenever there is more GFR, okay, if you ask me one condition where there is more GFR, for example, okay, let's see, this is afferent arteriole, here are the glomerular capillaries, and this is efferent arteriole. Afferent arteriole, glomerular capillaries, efferent arteriole. Okay, now there is this one condition, okay, there is this one condition which is called as diabetes mellitus. Diabetes mellitus. In diabetes mellitus, what happens? There is high levels of blood glucose. Okay, there is high levels of blood glucose. Now this high levels of blood glucose will love to, okay, this blood glucose, okay, it will love to stick to the blood vessels. We don't know the exact reason why, but this blood glucose will especially come and bind in the efferent arteriole. This process is called as non-enzymatic glycosylation. See, now glucose is getting deposited in the efferent arteriole. It causes non-enzymatic glycosylation, but at the end of the day, because of all these processes, now in this diabetes mellitus patient, there will be narrowing of the efferent arteriole. If the efferent arteriole is narrowed means, what happens? Sir, efferent arteriolar vasoconstriction increases the GFR, increases the GFR. Okay. Now, whenever there is more GFR, there is hyperfiltration, more filtration. Yes, in diabetes mellitus patients, yes, there is hyperfiltration or more filtration is there. Okay. Now, that is not something good. Okay, more filtration, more damage to the kidney. So, that will cause diabetic nephropathy. Okay, that will cause diabetic nephropathy. But anyway, at the end of the day, what we need to do? Your kidneys, they have a role. Okay, they can regulate their GFR. How, sir? If there is more filtration means more NaCl is getting filtered or not? Yes. More the GFR, more NaCl is getting filtered into the Bowman's capsule. That more NaCl will go into the proximal convoluted tubule. In the proximal convoluted tubule, yes, NaCl will be reabsorbed. But now, more filtration, more NaCl is getting filtered. Now, this NaCl is going to macula densa. Now, this NaCl is going to the macula densa. Now, macula densa, now it will understand. All the time, macula densa is looking at the GFR. GFR is normal, or GFR is more, or GFR is less. How it will know about the GFR? By looking at the sodium levels. So, macula densa is sensitive to sodium. It is sensitive to sodium. If more sodium is coming to the macula densa means, okay, if more sodium is coming to the macula densa means, now macula densa understood. Yes, GFR is increased. Now, what this macula densa is going to do? It have to decrease the GFR. How it will be done? Now, this macula densa is going to produce a substance called as adenosine. Okay, it's going to produce a substance called as adenosine. Okay, in this video, in the beginning we have seen adenosine, what it will do? Adenosine is going to act on the afferent arterioles. Adenosine, norepinephrine are going to act on the afferent arterioles, will cause afferent arteriolar vasoconstriction. So, there is afferent arteriolar vasoconstriction. So, whenever there is afferent arteriolar vasoconstriction, what happened to the GFR? GFR increases. So, in any condition, if there is increased GFR means, so automatically GFR will be brought back to normal with the help of macula densa. So, macula densa is present where? On the tubule, on the distal convoluted tubule. So, now the tubule is speaking, it is communicating with the glomerulus. Okay, it's communicating with the glomerulus. So, this is called as tubulo-glomerular feedback. The tubule is giving feedback to the glomerulus to decrease the GFR. Okay, so tubulo-glomerular feedback is given by macula densa. It's given by macula densa. Macular densa is present on distal convoluted tubule. Okay. Now after this, let's discuss about conditions where GFR is going down. Okay. If GFR is going down means what happens? If GFR is going down, that's not again good. Why? Because if GFR decreases, urine output decreases, urine volume decreases. So the bad substances, okay, the metabolic wastes are going to accumulate in the body. Creatinine accumulates in the body. Blood urea nitrogen accumulates in the body. That causes azotemia, uremia. That's something not good. Okay, something not good. So whenever GFR is going down, what you need to do at the end of the day, you need to increase the GFR. How that actually happens? Whenever there is decreased GFR, yes, less sodium is getting filtered. Now less sodium is reaching the macular densa. Now macular densa understood. Okay, less sodium is coming means GFR is decreased. Now macular densa, it will ask its friend. Okay, now macular densa, it's going to ask its friend. The friend is nothing but the JG cells. Okay, now it is going to stimulate the JG cells. Okay, now the JG cells are stimulated. Now these JG cells, what they are going to do? Now these JG cells, they are going to release renin. Okay, they are going to release renin. So now we know that JG cells releases the renin. What renin will do? Converts the 𝗠𝐤𝐵𝐷 into angiotensin 1. Angiotensin 1 will be converted into angiotensin 2. Now renin is going to ultimately produce angiotensin 2. Now what this angiotensin 2 will do? Angiotensin 2, yes we know, angiotensin 2 is going to act on the efferent arterioles. Efferent arterioles causes constriction of the efferent arteriole. Once the efferent arteriole is constricted means, okay, efferent arteriole is constricted. What happened to the GFR? See, GFR is increased because efferent arteriolar vasoconstriction. Okay, so these are the conditions where whenever increase GFR, the GFR will try to come down. Whenever the GFR is going down, your macular densa will try to increase the GFR. So this is something called as the tubuloglomerular feedback, and tubuloglomerular feedback is gained by macular densa, and macular densa is sensitive to sodium chloride levels. Okay, mainly sodium levels. Now after this, let's discuss about high protein diet and GFR. Okay, so protein diet and GFR changes. Okay, how protein diet is going to alter the GFR. Okay, now look at here guys. For example, think that you have a high protein diet today. Okay, today you attended a party. Now in this party, you have consumed a lot of meat. Okay, you have consumed a lot of meat. Now what happened to that meat? Meat will be digested in the intestines. Okay, it will be digested in the GIT. Now that is going to release the amino acids. Now all these amino acids are going to come into your blood, and from the blood all these amino acids are going to be filtered into the glomerulus. Okay, all the amino acids are filtered in glomerulus into the Bowman's capsule. Okay, Bowman's capsule. Now all these amino acids, see, now all these amino acids need to be reabsorbed or not? Yes, amino acids are very important substances. Okay, you cannot simply put the amino acids in the urine. So on the day when you have high protein diet, more amino acids are getting filtered. Important point, please concentrate here. See, let's take this as a proximal convoluted tubule. Okay, here is the Bowman's capsule on the top. Now what are these? These are the epithelial cells of the proximal convoluted tubule. Okay, so now what is happening? Now more amino acids, see, more and more amino acids are getting. Now amino acids are coming like this. Now you cannot simply lose this amino acid. So what happens? You need to take these amino acids back into the cells. Now point is, these amino acids, they cannot go alone. Okay, amino acids, they cannot go alone. Why? Because already in the cells, more amino acids are there. So these amino acids, they cannot directly go into the cell. Why? Because it's against the concentration gradient. So now what happens? They will only go along with the sodium. Why? Because the sodium concentration in the lumen is more and the sodium concentration in the cell is less. Okay, the sodium concentration in the cell is less and the sodium concentration in the lumen is more. So now sodium is moving from high concentration to low concentration. Now if anything is moving from high concentration to low concentration, it releases the energy. By using that energy, now even these amino acid molecules are going to be reabsorbed. These amino acid molecules are going to be reabsorbed. So what is the point? Amino acid molecules are reabsorbed only along with the sodium. This is called a sodium amino acid cotransport. Even this is same for the glucose also. Okay, same, glucose also cannot go into the cell directly. Glucose will have to take the help of sodium. So that is sodium glucose cotransport. So now what I am trying to put into your mind, so on that particular day when you have high protein diet, you will be having high amino acids filtration into the kidneys. Now all these high amino acids in the nephron need to be reabsorbed in the PCT itself. Now you cannot reabsorb only the amino acid, but the amino acids need to be reabsorbed along with the sodium. So more amino acid reabsorption means at the same time more sodium is also getting reabsorbed. Okay, on that particular day when you take high amino acid diet or high protein diet I should say, now more sodium is getting reabsorbed into the body. Okay, more sodium is getting reabsorbed into the body. When more sodium is getting reabsorbed, what happened to the amount of sodium that is reaching the DCT? The amount of sodium that is reaching the DCT or the macula densa is getting decreased. Now let's see, more sodium is reabsorbed in the DCT. So the amount of sodium reaching the macula densa is getting decreased. Now what happens? Now what macula densa will think? No, sodium is not coming. If sodium is not coming means what it will do? Sodium is not coming means it will activate. Macula densa is going to activate the JG cells. Now the JG cells are going to produce renin. So RAS pathway is activated. Angiotensin 2 is produced. Now what this angiotensin 2 will do? Angiotensin 2 will cause efferent arteriolar vasoconstriction. Whenever there is efferent arteriolar vasoconstriction, that increases the GFR. So on that particular day when you take high protein diet, say your GFR increases, your urine output increases. Okay, so why means efferent arteriole is vasoconstricted. On that particular day when you take high protein diet meat, your BP will be more. Why? Because RAS pathway is activated, angiotensin 2 is there, so there is increase in the GFR. Okay, so with this we have completed the changes in the GFR, alterations in the GFR, when the GFR is increased, when the GFR is decreased. Now not only that, I want to discuss here like some important concepts. Okay, now here let's discuss some important concepts like why ACE inhibitors. Okay, why ACE inhibitors are absolutely contraindicated in condition called as bilateral renal artery stenosis. Okay, so there is this one condition called as a bilateral renal artery stenosis, which means, see, this is the abdominal aorta, we all know. Now from the abdominal aorta, who is going to come out? It is the renal artery. Now this renal artery is going to kidneys, we know. Okay, at the level of L2, renal arteries are coming. These renal arteries, where they will go? They will bring the blood to the kidneys. Now in this condition, what is happening? The bilateral renal arteries got stenosed. Okay, now what happened to the amount of blood going to the kidneys? The amount of blood going to the kidneys, that is a renal blood flow. So renal blood flow is going to be decreased. If renal blood flow decreases, what happened to the GFR? GFR is decreased. Now if GFR is decreased, what happens? Sir, whenever your GFR decreases, your kidneys will try to regulate it. See, now please concentrate here. Just now we have discussed, whenever your GFR is going down, macula densa is activated, JG cells are activated, RAS pathway is activated, angiotensin 2 is produced. Now this angiotensin 2 is trying to regulate the GFR, is trying to increase the GFR. So in that person, in any person, if GFR is going down means RAS pathway is activated and RAS pathway is trying to maintain the GFR. RAS pathway is trying to maintain the GFR. Okay, so we need RAS pathway. Whenever GFR is low, yes, we need RAS pathway to maintain the GFR. Now for example, see, our patient is having bilateral renal artery stenosis. Okay, he is having bilateral renal artery stenosis. Now in this person, what is happening? Now his renal blood flow decreases, his GFR decreases. Whenever his GFR is decreased, what happens? Macula densa is activated, JG cells are activated, RAS pathway. Okay, RAS pathway is activated, angiotensin 2 is produced. Now this angiotensin 2, what it will do? It will cause efferent arteriolar vasoconstriction. So that is trying to regulate the GFR. In this person, this is the only hope. The only hope is the RAS pathway. Now in this person, okay, RAS pathway is more. So when RAS pathway is more, his BP will also be more. Okay, he is having hypertension. Now he is coming to your clinic. Okay, you are the doctor. He is coming to your clinic, and you measure the BP. Now in this person, the BP is more. RAS pathway is activated. BP is more. Now for example, if you give some antihypertensive medication, there are many antihypertensive drugs. Okay, there are many antihypertensive drugs. One of the antihypertensive drug is ACE inhibitor. Okay, ACE inhibitors like captopril, enalapril, perindopril, ramipril, ACE inhibitors. ACE ACE inhibitors are also antihypertensives. Okay, antihypertensive drugs. So the point which I want you to know is, see, now in this person, yes, RAS pathway is active. RAS pathway is trying to maintain the GFR, but the RAS pathway is also having hypertension. That's also causing the hypertension. Now, if you want to decrease the hypertension, you can use these drugs. Usually, we use these drugs, ACE inhibitors, they are antihypertensive drugs. So, what you have prescribed, you doesn't know that this patient is having bilateral renal artery stenosis. You don't know that thing. Okay? You don't know that thing. What you know is only this patient is having hypertension. So, now what you have prescribed? You have prescribed this person the ACE inhibitors. Now, what will happen? He will be having kidney failure. Why? Why? Because, see, these ACE inhibitors, yes, they will decrease the hypertension. By how? By inhibiting the RAS pathway, by inhibiting ACE, angiotensin converting enzyme, important enzyme in RAS pathway. The moment you give these ACE inhibitors, now ACE inhibitors inhibit the RAS pathway. So, RAS pathway is inhibited. When RAS pathway is inhibited, yes, there is no angiotensin 2, no angiotensin 2. Whenever there is no angiotensin 2, efferent arteriole is not going to be vasoconstricted. So, GFR, now it will fall. GFR is going to fall and this patient will have symptoms of 𝐒𝐻𝐵𝐞. Okay, the bad substances, okay, creatinine, blood urea, nitrogen, they will start to accumulate in the body and later it will cause even uremia. So, that's why never ever give the patient who is suffering with bilateral renal artery stenosis ACE inhibitors. Don't give it. Okay, don't give it. Okay, don't try to stop the RAS pathway. Okay, use some other antihypertensive medications. Okay, so with this we have completed the topic of changes in the GFR, alterations in the GFR, and also we have discussed the one important topic, that is autoregulation of the GFR. Hope the video is helpful. Thank you.